Hi, today I'd like to discuss about adrenal gland disorder in pediatrics. So this is the video lecture number 4 in the video lecture series for the academic half day. So we will review this adrenal gland disorders during the session April 29th. So I hope you have a chance to review this video before the session. So when we talked about adrenal, there are two histological layers. One is called adrenal cortex, and the other one is adrenal medulla. So in endocrinology, the more important layers is adrenal cortex. So within the adrenal cortex itself, there are 3 additional layers. One is the zona glomerulosa, which secretes mostly aldosterone, zona fasciculata, which secretes mostly cortisol, and the innermost zone called zona reticularis that secretes mostly adrenal androgens. So I'd like to go back to this hypothalamic pituitary control that we have discussed with the other sessions as well. So for adrenal gland, the axis is called hypothalamic pituitary adrenal gland axis, or HPA axis. So hypothalamus secretes CRH, which then stimulate corticotrophs in pituitary to secrete ACTH. The ACTH itself then stimulate adrenal gland to secrete adrenal hormones, which is the steroid hormones. So once the steroid hormones bind to the nuclear receptors, it complete the feedback loop. It sends the feedback loop signal back to the hypothalamus and pituitary, completing the HPA axis loop. So if there is a problem that adrenal gland causing adrenal insufficiency, we call this primary adrenal insufficiency, similar to thyroid. If there is a problem at hypothalamus and pituitary, we call this together a secondary adrenal insufficiency or central adrenal insufficiency. So these are the terms that we use in identifying the cause for adrenal insufficiency. So for hypothalamic pituitary adrenal axis, once the ACTH stimulate adrenal cortex, it can stimulate both all of the adrenal hormones. So it can increase the cortisol production, aldosterone production, and androgen productions, and each bind to its specific nuclear receptor. So cortisol binds to the glucocorticoid receptor, aldosterone binds to mineralocorticoid receptor, and androgens binds to adrenal androgen receptor. However, aldosterone itself has a special system that controls its secretion, which many of you have already familiar with, which is renin-angiotensin-aldosterone system. So this is another system that can control aldosterone independent of ACTH. So adrenal hormones, the 2 most important ones are cortisol and aldosterone. So cortisol itself is a stress hormone. It maintains the blood sugar and vascular tone and has many other actions. For aldosterone, the main functions are to preserve sodium and excrete potassium, and also acid excretion. So the main function of aldosterone is in the kidneys. You probably have already heard about diurnal variation of the cortisol production. So this is a graph depicting the diurnal variation. So adrenal gland secretes cortisol at the highest level in the morning at around 8 o'clock. And the level of cortisol decreases throughout the day and reach the lowest point at nighttime. However, this diurnal variation is not mature until 2 years of age. So this makes it a little more difficult to interpret cortisol level in newborns because of the lack of diurnal variations. So when should you suspect that the patient has adrenal insufficiency? So as I mentioned earlier, cortisol has many functions as well as aldosterone. So the symptoms of adrenal insufficiency is very broad. So you can have patient with rapid weight loss, fatigue, or hyperpigmentation. Some patients may present with hypoglycemia, electrolytes abnormalities such as hyponatremia, hyperkalemia, or acidosis. So, or in patients that has brain tumor that receive surgery and have radiation, we often check the adrenal function in those patients as well. Or it could present in the newborn as a hypoglycemia, hypotension, or electrolytes abnormality. Or in some patient with other endocrinopathy known to associate with adrenal insufficiency, such as in the autoimmune polyglandular syndrome type 1, in which the patient has autoimmune destruction of several endocrine glands. So for primary adrenal insufficiency, as I mentioned earlier, the problem is at the adrenal gland. So what happened is that you would have a decreased production of cortisol and aldosterone, which then send a positive feedback to hypothalamus and pituitary, which then stimulate an elevation of ACTH level. So in primary adrenal insufficiency, the hormonal abnormalities you will see is low cortisol, aldosterone, elevated ACTH. Right, this is just a repetition. So in primary adrenal insufficiency, you'll see a low cortisol with elevated ACTH, low aldosterone, and also very elevated renin. Remember, because renin, angiotensin, aldosterone is another system that controls aldosterone production. So this is a hyperpigmentation that you can observe in primary adrenal insufficiency. So what is the cause of hyperpigmentation? Remember, ACTH is secreted as a long peptide called POMC, pro-opiomelanocortin. The POMC gets cut into different fragments. One of the fragments is melanocyte stimulating hormone, or MSH. So MSH can be elevated when you have a primary adrenal insufficiency causing hyperpigmentation. As you can see in this picture, this is the area where the patient has hyperpigmentation. Another area where you can clearly see hyperpigmentation is inside the gum line or the buccal mucosa. And also this patient has on the nails. Now, what are the causes of primary adrenal insufficiency? So there are a total of 5 categories. Congenital, the one that we most familiar with is congenital adrenal hyperplasia, or CAH. Infection, in the past, meningococcemia has been a classic description of an infection that can cause primary adrenal insufficiency. Trauma, such as bilateral massive adrenal hemorrhage, right, which can be found in newborn period. Also autoimmunity, which is probably one of the most common cause of primary adrenal insufficiency in children and adults, which is called Addison's disease. Or you can have toxic substance such as ketoconazole and mitotane that is very toxic to adrenal cortex, causing a primary adrenal insufficiency. So what is congenital adrenal hyperplasia? So it is a genetic defect in one of the enzymes that involves in adrenal steroidogenesis, leading to the deficiency of cortisol and aldosterone. So because of the deficiency of these 2 hormones, there is a positive feedback that causes an extremely elevated ACTH, result in adrenal hyperplasia. So this is a histological term that before they discover the hormonal defects, they found that the adrenal gland of these patients are extremely large, hence the name congenital adrenal hyperplasia. As we all know that there are many forms, but 95% of the cases are due to 21-hydroxylase deficiency. So this is the most simplified steroid pathways. So cholesterol is a precursor of all steroids. So cholesterol has to be transported into mitochondria and converted to pregnenolone. Pregnenolone then becomes progesterone, which is a precursor of aldosterone. And progesterone itself will be converted to 17-hydroxyprogesterone, which is a precursor of cortisol. At these steps, 21-hydroxylase enzyme is a common enzyme used in both pathways. So what happened in patient with CAH who has a deficiency of 21-hydroxylase? So you have a blockade here, which results in an accumulation of 17-hydroxyprogesterone. And you have a deficiency of both aldosterone and cortisol. So elevated 17-hydroxyprogesterone will be converted to androgens, which then can masculinize external genitalia in an XX individual. This is a reason why in a severe form of 21-hydroxylase, if it occurs in an XX individual, that patient would have masculinization of external genitalia, right? So this is one of the disease that we screen in the newborn screening. The reason we're screened for it because we want to detect the CAH before adrenal crisis occurs, right? So if adrenal crisis happens, patient can die. So this is the reason why the newborn screening program starts screening for CAH. And the screening hormone will be 17-hydroxyprogesterone, which is the most sensitive hormone as a screening for this condition. So how about secondary adrenal insufficiency? So you probably are familiar with this feedback loop already. So the secondary describe a problem either hypothalamus or pituitary, which then leads to a decrease in ACTH hormone. So ACTH hormone is a very important stimulating hormone for adrenal glands. So without a stimulation from ACTH, adrenal glands gets atrophy, right? And a decreased production in cortisol. However, as I mentioned before, aldosterone can be controlled by renin-angiotensin-aldosterone system. So in a secondary adrenal insufficiency, patient can have sufficient amount of aldosterone production to prevent adrenal salt wasting, right? However, patient will still have low cortisol and low to normal ACTH, right? So as we call inappropriately normal ACTH level. Right? So many times it's very difficult to distinguish between primary and secondary. So sometimes we use a synthetic ACTH to stimulate the adrenal gland to help distinguish between primary and secondary. So what are the causes of secondary adrenal insufficiency? Very similar to other hormones that's controlled by hypothalamus and pituitary. Right? For congenital, it can be caused by hypopituitarism, right? So you have a deficiency of all pituitary hormones. You can have an infection such as meningitis, which is a pretty rare cause of secondary adrenal insufficiency. But you can have patients with brain tumor that have brain surgery and radiation, right? So causing a destruction of the hypothalamic pituitary control of the adrenal gland, causing secondary adrenal insufficiency. Now, you all probably have heard about adrenal suppression, right? So what is adrenal suppression? So adrenal suppression is caused by a supraphysiologic dose of glucocorticoids, right? And a prolonged use of high-dose glucocorticoids, which then can suppress the hypothalamic and pituitary axis, right, in a negative feedback loop. So when you have a very suppressed hypothalamic pituitary axis, the ACTH level is low. So it caused an atrophy of adrenal gland. So during the time the patient is taking glucocorticoids, they won't go into adrenal crisis because they have sufficient amount of glucocorticoid from the medication they're taking. But the problem happens when you have a sudden cessation of that glucocorticoids. So you stop giving glucocorticoid abruptly. So the patient's HPA axis has not recovered, right? So this caused a inadequate production of cortisol and causing an adrenal insufficiency. However, as I mentioned before, this is considered secondary adrenal insufficiency. So the renin, angiotensin, aldosterone is intact. This is probably the most common cause of secondary adrenal insufficiency that you'll see in clinical practice. Also, patients often have cushingoid appearance. Like in this patient, you see a moon phases, stria, and also truncal obesity. So this is a features of patient who's been receiving glucocorticoid for a long period of time. So what are the treatments of adrenal insufficiency, right? So we know which hormones are deficient, so we replace both hormones, right? So in primary adrenal disorders, we have to give them glucocorticoid, which is the synthetic one is hydrocortisone or Cortef. And mineralocorticoid, the synthetic form is called fludrocortisone or Florinate, right? So in primary adrenal disorders, patient will require both Cortef and Florinate. However, in secondary adrenal insufficiency or central adrenal disorders, as I mentioned earlier, the renin, angiotensin, aldosterone system is intact. So patient only requires hydrocortisone as a treatment. So this is all I want to review for today. So during the session, we will review the case with adrenal gland disorders. So thank you for listening, and I hope you enjoyed this video.